Time flies, it's October already. In October, we celebrate breast cancer awareness. In line with that, we have with us today at our podcast Dr. Jessie Hu, breast surgeon, and Dr. Lynette Ngo, a medical oncologist. Welcome to our podcast, doctors. Thanks for joining us today.
Hi, I'm Dr. Jessie. I'm actually a breast surgeon in FEM surgery. So my interest is actually oncoplastic breast cancer surgery, which means we use plastic surgical techniques to remove breast cancer in the patient so that we can retain the aesthetics of the breast.
Hello, I'm Dr. Lynette Ngo. I'm a medical oncologist in Curie Oncology. My subspecialty training is in women's cancers, breast and gynae cancers. I'm really happy to be here.
Everyone is aware of breast cancer. It's really prevalent today. I want to talk about the different stages of breast cancer.
It's been found that cancers slowly start from an abnormal cell in either the duct of the breast or the fat lobules of the breast. And then when they slowly mutate and they grow, then they might start spreading through the drainage system of the breast, like the lymphatics or the blood vessels. And then they move to the lymph nodes and subsequently to other parts of the body. And according to the prognosis, it is dependent on each stage where the cancer is diagnosed. They stage cancers according to stage 1, 2, 3, and 4. So stage 1 is when breast cancer is confined to the breast. Stage 2 is when the size is larger or it has spread to the draining lymph nodes. And then stage 3 is when it's more than 5 centimeters or when more lymph nodes are involved. And then stage 4 is when the breast cancer has spread out of the breast and the draining lymph nodes to other areas of the body.
In your practice, I'm sure you've seen many breast cancer patients. Which ones are easier or harder to treat? Is it stage dependent?
Oh, yeah. In the past, we used to mainly classify patients according to the stage and treat them according to the stage. So yes, the stage would be important in terms of how intensive or of the treatment that they require. But after some time, they realized that breast cancer is also not just one single cancer. There are actually many different subtypes of breast cancers. And they have found by looking at the structure and the immunohistochemistry of the breast cancer, they found that there are actually several types according to the biology of the cancer. So one of the most common types of breast cancer is the hormone receptor positive breast cancers. So these cancers are very hormone sensitive. 50 to 60% of all breast cancers are hormone sensitive breast cancers. Another 20%, they seem to carry a protein called HER2 on it. These define a more aggressive sort of breast cancers. They tend to spread faster. They tend to also grow very quickly. And then another type of breast cancer is the triple negative breast cancer. This subtype of breast cancer is the most rare, comprising maybe about 10 to 15% of breast cancers, but they are also the most aggressive cancers. So they tend to grow very quickly and spread very easily as well. So the treatment, obviously, for these subtypes of breast cancers are different.
With so many types of scenarios when it comes to breast cancer, would you say that there's no one size fits all? So every case that you treat, you do follow a personalized treatment regimen?
Yes, absolutely. So not only do we look at the subtype of breast cancer to decide what sort of treatment, we also look at the patient factors themselves, the age of the patient, their fitness, whether they can tolerate treatment or not. So to personalize according to the subtype of breast cancers, we look at whether they are hormone sensitive or whether they are very aggressive subtypes like the HER2 and the triple negative. Usually the very aggressive subtypes like the HER2 and triple negative, because we want to prevent the cancers from spreading quickly, a lot of the times we start with chemotherapy treatment first or targeted treatment against the HER2 cancers, and then followed by surgery. On the other hand, the more slow-growing subtypes like the hormone receptor positive cancers, usually surgery is the first treatment for them.
We've heard from the oncologist, now we will speak to the surgeon. So Dr. Jessie, this will be your area. Is it possible to treat breast cancer without surgery? Do you get this question a lot?
Yes, we do. So the truth is right now it's not possible. I tell my patients that surgery aim is to remove the cancer, and every other therapy, be it radiotherapy, chemotherapy, endocrine therapy or targeted therapy or immunotherapy, aim is to reduce the chance of cancer coming back. So they all work together. One doesn't go without another. So it's not possible to treat breast cancer without surgery. But having said that, surgery for breast cancer has evolved tremendously over the last 50, 100 years. 100 years ago, if you have a cancer, no matter how big or how small, it's a mastectomy, which is a removal of the breast and the axillary lymph nodes. And that is because we don't have all this adjunct treatment to help reduce the cancer coming back. Now that with all these drugs and treatment that we can give, we can actually do less surgery to get the same outcome. So surgery has evolved a lot.
Okay, so I guess in addition to taking the tumor out, you do recon as well, reconstructive?
Yes. So breast cancer surgery is very unique in the sense that there's no other cancer where your surgeon will give you a choice. Like if you have a colon cancer, they'll say, okay, you need surgery. We're going to remove it, and that's it. But for breast cancer, I always give my patients a choice. So the type of surgery very much depends on the size of the tumor in relation to the size of the breast, the location of the tumor, and ultimately what does the patient want. Okay, so when we talk about oncoplastic surgery, the onco, which is the oncological surgery, always comes before plastics. That means the aim is to remove the cancer. And the second aim is to retain the aesthetic outcome. So the aim of it is, I always tell my patients, no matter what surgery you choose, you can wear the same bra, same clothes you're wearing now, and nobody can tell that you had breast cancer and you had surgery. So the choice between a lumpectomy, which is a removal of the cancer lump itself, or a mastectomy, which is a removal of the breast, is very much individualized. It depends on what they want. And of course, even with removal of the lump itself, we have oncoplastic techniques where sometimes we can make the breast younger. It means we do like a breast lift so they can have perkier breasts. We can also upsize. So an age is not a barrier. I had a 62-year-old lady who wanted to upsize. So she had a mastectomy and she had implants. And of course, after reconstructions, there are various choices. We have autologous reconstruction where we can take fat from the tummy, from the back. And so if we take from the tummy, it's almost like a tummy tuck at the same time. We can even put in implants. So there's so many options right now to achieve the aesthetic outcome that a patient wants. Yeah, and we can also downsize. So I have patients who have E-cup breasts who always wanted to have smaller breasts. So they had to remove the cancer, make the breast smaller and younger looking. And we did the same on the other side to match.
So would you say that there's any type or stage of breast cancer where surgery is imperative?
The only time we don't do surgery is when it's stage 4 breast cancer. That means if it has gone to other organs like the liver, the lung, or the bones, where surgery is not going to improve the prognosis. And if we ever do surgery during that time, it's mainly to help palliate. It means the patient feels mainly for wound control and all that. But in all other stages, surgery is always part of treatment. It may not be the first thing we do, like what Dr. Lynette was talking about, the triple negative and the HER2 positive cancers. Most of them, we will offer chemotherapy first, which we call neoadjuvant chemotherapy, which is chemotherapy before surgery, so that we can help to either downsize the tumor and at the same time prognosticate how the tumor responds to chemo. But after that, we still have to do surgery to remove the area where the tumor was so that we can conclusively determine how much cancer is left behind after chemotherapy.
So I have a question here. If I do a breast recon and I have implants, will that affect my treatment after, like radiation treatment or chemotherapy? Do implants actually affect treatment after surgery?
Yes, in a way that we try to avoid radiation therapy after implant because there's a higher risk of capsular contracture and it may affect the aesthetic outcome of the breast itself. But there is always a way to do a stage procedure. That means you can put a temporary implant to keep the space open. And then if we need radiation therapy, after radiation therapy, then we put in the actual implant. But I don't think it affects chemotherapy.
No, it doesn't.
Yeah. Of course, there are certain patients where the tumor size is much bigger and we cannot conserve the breast to give a acceptable aesthetic outcome. Generally, if the tumor is more than 25% of the breast, we cannot just do a simple lumpectomy, just to remove it, because that will cause a distortion of the breast. So anything more than 25% up to 50%, we can still use oncoplastic techniques to reshape the breast, or to take tissue from the side of the breast and the side boobs to fill it in to achieve an aesthetic outcome. But anything more than that, unfortunately, sometimes we have to do a mastectomy, because if we cannot achieve a shape that is, we can have a smaller breast, but the shape should still be there. If we cannot achieve that, then there's no point doing a lumpectomy, because it defeats the purpose. Yeah.
I'd like to ask a question that is probably very common from your patients, the concept of recurrence. Dr. Lynette, in your practice, would you say that certain stages have a higher recurrence rate than others?
Yes, the patients with a higher stage of breast cancer would have a higher risk of recurrence. Certain subtypes also tend to have a higher risk of recurrence, like the HER2 and the triple negative cancers. But if they've gone through the standard chemotherapy treatments, generally their risk would have reduced to that of the usual breast cancers.
What about guys? Have you had any male patients, and what was their journey like?
Yes, I do have a couple of men breast cancer patients, and we don't treat them any differently, except that breast cancer is so rare in men that there must be an underlying reason for that. And a lot of the times it's related to hereditary breast cancer. So we often would send them for genetic counseling and discuss genetic testing with them. That would be an important part of the management of breast cancer for them.
The journey is pretty much the same, basically.
Yes. So again, if they have high stage breast cancer, they would may require chemotherapy. We would still subtype them according to the subtypes of breast cancer and treat it accordingly. They're not any different from female breast cancers.
When do you do chemo and when do you do radiation? Is there a difference?
Yes. So radiation is okay. If you are talking about early breast cancers, then chemotherapy and radiation are mainly to prevent a breast cancer recurrence. Radiation is mainly to prevent breast cancer recurrence locally, which means in the breast, in the chest wall, and in the lymph node area around the. So radiation prevents recurrence in that area. However, chemotherapy would prevent recurrence in any part of the body, which could include a recurrence in the liver, bone, brain. So they work together, but differently as well. I think the breast cancer in males is probably, to me, is interesting to hear from the surgeon. Is there a difference in the way you manage them surgically?
Well, there's no such thing as a lumpectomy for male breast cancer, so they all go for mastectomy. And Dr. Lynette has pointed out that there is usually a genetic component, so we will do gene testing. And also, actually, men can go for mammogram as well. So that is part of the investigations that we do when they have a male breast cancer, to do mammogram on the other side, because usually they present with a lump because they don't have much breast tissue. So when they come to us, they usually have a lump, or sometimes they have a nipple change or nipple discharge. And then we do a biopsy and we confirm that there's a cancer on one side of the breast. And then as part of workup, we usually need to make sure there's no cancer on the other side. And part of the workup is to send them for a mammogram on the other side. So having said that, if a lady tell me that my breasts are too small for a mammogram, I'll tell them that if a man can go for a mammogram, you can too.
Have you had a lot of male patients?
We have a few. So for every 100 female breast cancer patients, we'll see one. So that is the ballpark figure. But generally, they are older.
Oh, like what age?
60s, 70s.
So you don't see it in like younger?
I think overall in cancer, we see in older patients, although I feel that there's a trend that there are younger ladies who are being diagnosed. I'm not sure whether it's an environment or lifestyle thing, but why do older people get cancers? It's a very simple thing. As you get older, your cells change. It cannot be fixed. So it's like a car, after a while things break down, and that's when cancer starts. And that's why if you look at populations, the like maybe 50 years ago, Singapore don't have that many people with cancer because they die from infectious disease. But now that we live longer, we have more patients with cancer because it happens with age. But if we picked up a young breast cancer, young meaning anyone less than 40, then we are more concerned whether there is a genetic component, whether it's hereditary, and that's when we start thinking about whether we send them for gene testing.
So I guess with breast cancer, like hormones come into play a lot, right?
Yes.
Like hormones decide a lot.
Yes and no. So like what Dr. Lynette has pointed out, 60% of breast cancers are hormone receptor positive. So the hormones, like we're talking about female hormones like estrogen and progesterone, they drive the growth of the tumor itself. And these hormones are present in male and female, and whether you're postmenopausal or not, it's just how much is present. So that's why the treatment of it, part of it to reduce the risk of coming back, is anti-hormone therapy.
Genetic testing is like the in word now, right? For oncologists. And this is quite like a new thing. What are your thoughts on genetic testing in terms of cancer prevention?
I guess in the past, genetic testing was mainly done because there was a strong family history and people wanted to know if they were at high risk of developing cancers. But it also became very unpopular because people started to ask, what's the point of knowing if it's just a death sentence? So they would rather not know than know. Nowadays, things have changed because they found that actually there are targeted medications like PARP inhibitors, which patients with the genetic mutations actually respond very well to. So not only is it diagnosing their risk, but also there are treatment options available for people with the genetic mutations. Because of that, the indication for genetic testing is increasing. We would usually recommend genetic testing in anyone who is a rare cancer, or such as breast cancer in a man, or cancer that develops in a very young person, because as what Dr. Jessie mentioned, most cancers develop when they are much older. So if a very young lady has breast cancer, we would also want to know what's the cause of that.
So would you say that when breast cancer manifests in a younger person, it is largely a hereditary issue?
Oh, there are many causes for cancer. One of them would be hereditary, because genetic mutation is so rare. And if a young person has breast cancer, then that would be one of the thoughts that would go through our minds. Yeah. But there are certainly other causes as well.
You know, we talk about screening and prevention, and a mammogram would be the most likely thing to do. I think some people are still nervous about going for mammograms, and there's some misconception about mammograms and radiation.
Sometimes we get patients who, with the first mammogram, pick up something but not sure. So we need to send them for a diagnostic mammogram, which is an additional mammogram. So a lot of patients are like, oh no, what if I get, this radiation? Is there a risk of having cancer with radiation for mammogram? But the truth is, the radiation dose for mammogram is actually very low. And there's always background radiation all the time. And the radiation is increased when we take an aeroplane flight. So I always tell them, the amount of radiation you get exposed from a mammogram is the same as if you fly from Singapore to Tokyo. So the radiation risk is actually very low in terms of cancer developing. And I think the other buzzword now is 3D mammogram. Everybody else wants to do 3D mammogram.
Really? So what is 3D?
3D mammogram is just a sexy term for tomosynthesis. It's been around for the longest time. We just said recently they want to give it a nice name called 3D mammogram. It's actually a mammogram with multiple x-rays to put it together to make it 3D. So 3D mammogram has its pros and cons. So sometimes the argument of pros is it can pick up masses more and dense breast patients with dense breast tissue. So density of the breast can only be determined on the mammogram. It's what you're born with. You can't change anything about it. Dense breast, it makes mammogram reading more difficult because when the breast tissue is dense, the mammogram looks more white in general. And breast cancer or masses look white as well. So you can imagine a white thing on a white background is hard to pick up. So that's why if you look at your mammogram report, there's always this fine print line at the bottom that mammogram can miss up to 20% cancers. That's the truth of it. So some patients were like, oh, I had my mammogram just 3 months ago as normal and now I have a lump. It shouldn't be a cancer. I think that's a very big myth, because sometimes we do have patients with cancer who are not seen on mammogram, not seen on ultrasound, not seen on MRI, but we can feel it and we see it's a cancer. So there's no one imaging that is 100% sure proof. That's why we always advocate breast self-examination. Breast self-examination is not about being an expert in examining breasts. It's about being an expert in your own breast. So you know how your breast tissue feels like. And if there's any change, you know. Because a lot of us don't look at our breasts. We look at our face. You know, if a new pimple pop up or a new wrinkle comes up, we know. But if a new lump, we don't know because we don't look at it. We don't feel it. So the breast self-examination is knowing how your breast feels like. So if there's a new lump or new change, you can pick it up early. And because even if you go for regular screening with your doctor only see you every 6 months or a year, things can happen in between. And so that is part of how we can try to pick up cancers early, because the earlier we pick up cancer, the less we need to do and the better your outcome is. Yeah. And AI, I think they also, for tumor board, they do have AI as well to help to make decisions, because tumor board is where the various doctors who treat breast cancer patients, when we discuss what is the best treatment for the patient, most of the time, I think 80-90% of the time, is quite clear cut. We kind of know what is it. And so they're like, okay, this is, the AI will tell you that based on this is what it is. And then we'll see whether we agree or not. In about 10% of the time or less, we have a very long discussion about what is the best way forward, because some patients are a little bit more different. And that's where, when we talk about individualized treatment, there's no one size fits all. We go based on the patient profile, how old the patient is, the family history, what kind of tumor subtype, the stage, and also the breast size, and ultimately what the patient wants. And it's a very long discussion to tailor the treatment based on how the patient is. And that's why AI cannot do that, because you cannot put in all these factors.
Have you had patients asking to do an ultrasound instead of a mammogram?
So yes, because of the fear of mammogram, that is painful because of there's radiation. So I do have patients who say, "Oh, I had an ultrasound. Don't do my mammogram?" You can't, because they are complementary. One doesn't replace another. They look for slightly different things. So mammogram helps to pick up early cancer, what we call stage 0 breast cancer, or ductal carcinoma in situ, which means the cancer has not gone beyond the milk ducts and is all confined within it. And these usually don't present with a lump or mass. So they present with calcifications, which is like white spots on the mammogram, and that cannot be seen on ultrasound. That's what mammogram does. Ultrasound is a complementary to mammogram because, like I said, some breasts are very dense. When there's a mass, it may not show up on a mammogram. So the ultrasound helps to pick up such masses. But with any test that we do, there is always a positive and a negative side to it. Because ultrasound tends to pick up masses, it can tend to pick up a lot of what we call noise, like cysts and masses which are not cancerous but can cause undue anxiety to the patient. That's why before we do a test, it's best to discuss with your doctor like what is the best test forward. And also screening is also very individualized nowadays. It depends on the patient profile and family history. We tailor that accordingly to how frequently you need to screen and what kind of modality. So it's best to talk to your doctor about that.
Okay, so this is a pop question for our two ladies. When was your last mammogram?
Good question. I think doctors make the worst patients. When I'm busy, so I would postpone it. But yes, because breast cancer awareness month has just come out, and I booked myself a mammogram for next month. So yes,
same. Yes, we always make the worst patients.
Is it possible to get pregnant after cancer treatment?
Yes, definitely. Of course. Many women do. So it's not a contraindication. And nowadays we actually have medications that would reduce infertility after chemotherapy. We also refer them early on if they are very young and desiring a family to see the gynecologist to maybe freeze the eggs or the oocytes. So yeah, in the event that they want to have a family after that. So yep.
I guess it's a common misconception that it's very hard to get pregnant after cancer treatment.
Yes, because the anti-hormone treatments are for 5 to 10 years. And a lot of women want to have children after they complete their chemotherapy. So when to stop the treatment to have a baby is that tricky conversation that we need to have with the patients.
So you would have to stop these hormone treatments when they're trying for a baby.
Yes.
Do you use immunotherapy for breast cancer?
Yes, that's a good question. Immunotherapy became very popular because it was very effective in certain cancers like melanomas, lung cancers, kidney cancers, and they induced a very good response for a very long period of time, and with the promise that it could be chemotherapy free. Unfortunately, for breast cancer, it's not been found to be universally effective, but again, because we have now subdivided breast cancer into different biologic subtypes, we find that immunotherapy has a role in triple negative breast cancers. So even though triple negative breast cancers are the most known to be the most aggressive type of breast cancers, with no other treatment aside from chemotherapy, immunotherapy has been found to play a role. But not all triple negative breast cancers respond to immunotherapy as well. So only those with who express a certain type of biomarker like PD-L1, they have been found to respond very well to immunotherapy. Nowadays, we have found that immunotherapy in triple negative breast cancers, when we add it to chemotherapy and give it before surgery, it actually induces a much better response to chemotherapy, and with a chance of a complete response even before surgery. So that has become very promising and has also been shown to improve survival. So immunotherapy has a role in a small proportion of breast cancers, but it's been shown to work very effectively. The recent ESMO update has shown survival benefit of immunotherapy plus chemotherapy, but only for triple negative breast cancers, early breast cancers. A lot of people think that immunotherapy works by itself. Unfortunately, a lot of the times it's been found that it works effectively when it's given together with chemotherapy. So in a way, you can't quite omit the chemotherapy component of it.
Immunotherapy can be applied to all different cancers?
No.
Or does it work with certain cancers better than others?
Yes, certain subtypes of cancers. Usually the cancers that tend to be very mutated, very aggressive, so very fast-growing, very mutated. Yeah.
Do you refer patients to each other in your line of practice?
Yeah, we do, because there are many surgeons and medical oncologists, but I usually tend to refer my patients with breast cancer to medical oncologists who have special interests and deal with breast cancer mostly, because breast cancer treatment is constantly changing. So I think a lot of us make a point to attend conferences to know what the latest treatments are, because there's so much research out there and it keeps changing. You need to keep up to date to know what is the latest and best treatment for your patient. So that's why we do refer to each other.
Yes, I definitely do too. Even after the primary breast surgery, sometimes my patients tell me, oh, why must I continue seeing the breast surgeon? It's done already. But then I tell them the follow-up is important as well. They need to make sure they don't get a recurrence, especially in the breast again. So it's also important to continue seeing the breast surgeon.
This kind of goes into your survivorship territory, right? Survivorship is also a very important aspect nowadays. Now, how often or how long do you continue to see a patient after treatment is done?
Well, I tell them I grow old with them. I have to see them for the next 10 to 15 years just to make sure they are on the right track, they have reduced all their risk factors, and they don't have any recurrence.
I think it's more so for the med onco rather than the surgeon.
No, we see them forever. Until I retire, I guess. Because, okay, the truth is, because, like, for example, the hormone receptor positive cancers, that they tend to have late recurrences, like 20 years later. So that's why we tend to follow them up. And if they have a very good family doctor who they see regularly and who is willing to follow up and they're willing to do that, sometimes we do send to them after like 5-10 years. But sometimes a lot of Singaporeans don't have. So I think the Healthier SG is a good movement that will encourage this. If they are willing to have a family physician who will take charge of their health, I don't mind discharging them to the family physician after 5-10 years for follow-up. Because somebody needs to make sure that they get their mammogram regularly and breast check regularly. Yeah.
Have you encountered any inspiring patient stories in your line of practice?
Inspiring, yes, and interesting, of course, yes. So back to like breast reconstruction, I had one of my very first cases was this young lady who's 42 years old with breast cancer. At the time when she saw me, she was a very, very slim young lady with small breasts, 32 double A cup. So we did a mastectomy and reconstruction. The breast that I took out was, I still remember to this day, 88 grams. So you can imagine it's a very small breast. And we did a reconstruction with her tummy fat. Fast forward 5 years down the road, she's still seeing me. Now she has become a middle-aged lady who's more well endowed. She has put on some weight. Now she is, her breast size is probably a 36B. And amazingly, her reconstructed breast has grew as well. So now she has perfectly symmetrical breasts. And that can only happen when you have autologous reconstruction. So if you have an implant, it will have stayed the same size. And of course, she was a bit lucky because when she put on weight, her breast put on weight and her tummy fat put on weight. So her both breasts grew to the same size. Yeah.
Is that possible?
Yes, it is.
Obviously, evidently.
Evidently, everybody put on fat differently. You know, some of us, when gain weight, we put on fat in the thighs, and some people put on weight in the tummy only. For her, it just so happened that she put on fat on both the breast and the tummy fat. And so both grew at the same time with her increase in size. So now, the both breasts are symmetrical. But having said that, most of the time when we do reconstruction, we tell the patient try to maintain about the same weight and same size because we don't know whether the reconstructed breast will change or not. And a lot of times I have patients who have reconstruction and nobody know. Like yesterday, I just saw my patient who had a double mastectomy and implant reconstruction. And she told me even her best friends didn't know she had breast cancer. And they can't tell. I said, you look great with the clothes you wear. Nobody can tell. But she was trying to find a way to explain how she has a scar in her armpit because that's where we take the lymph node for testing. And so I had to come up with a story for her to explain why. I mean, to me, it's a little bit bittersweet because I feel that breast cancer is still a bit of a taboo. A lot of patients they're not willing to share that they have breast cancer, even with their close friends or even with their family. Like I had another patient who was diagnosed with breast cancer, and after I did the surgery for her and she came back and she told me, Dr. Jessie, I need to tell you something. I said, oh, okay, so what? She said, my mom told me she had breast cancer 3 years ago and she never told me. When I told you I know family history, I didn't know. And for the longest time I was wondering, why is she avoiding me? Why is suddenly we're not so close? So you can sense that it is so taboo that we are not even willing to tell our family. And that's why breast cancer awareness is so difficult because a lot of people are not willing to share. And just like a few months ago, I had another sharing section with ladies in a club talking about breast cancer awareness. And the inspiring thing was this lady who was in the club for the last 20 years suddenly decided to share. She said, guys, I had breast cancer 10 years ago. I'm a survivor. And nobody knew. But it was very inspiring because I said, look, you look perfectly well, perfectly normal looking. Nobody can tell you had cancer surgery. So I think that is the biggest challenge and barrier we have at this time. Even to get people to say breast is difficult.
Is it really?
Yeah.
But I guess everyone is different and you want privacy on your...
Yes, so we
journey.
respect their privacy. We will never tell anyone that they had cancer if they don't want to share. Sometimes it's good for them to share with their close friends or family so that they can get the support they need.
How about Dr. Lynette?
There are miracles and there are also inspiring patients. Like I treated a lady who was pregnant when she was diagnosed with breast cancer. And it was very turbulent, very difficult. And Unfortunately, I think she had one of those breast cancers that was hormone receptor positive, and tamoxifen or one of those anti-hormone medications, they are contraindicated during pregnancy. So I had to give her chemotherapy during pregnancy. But she was very strong, and she decided that she would go ahead with it because she's a young mother, has a young family. And so we went through chemotherapy with her in the second trimester, and we monitored very closely. Her gynae saw her before and after every chemotherapy to scan the baby to make sure the baby was okay. And then how she finished her the chemotherapy, delivered a healthy baby, everything was good. And then now the baby is like 4 years old. He comes running around in our clinic, and she brings him every time. So cute, so inspiring. Yeah, and I guess the other group of patients that always inspire us are the ones who defied the odds. Like I had stage 4 cancer patients who were seen in another hospital, and I guess the usual standard spiel in a patient who is diagnosed to have stage 4 cancer is that you have 6 months or less to live. So that's what they told her, and then the family was devastated. And then she came, and then she had a complete response to chemotherapy. And now she's my longest standing alive patient at 9 years with stage 4 cancer. She's doing so well, and complete response. So no sign of cancer, and she's still doing well. And she's grown old. So she rolls in a wheelchair, and she would always fling a bag of buns to me because she says I never eat at lunchtime. So she said, "You must eat, 医生你要吃." Then she will give me all those breads and all that. Yeah.
So you're seeing 9 years on and you're still seeing her?
Yes, I'm still seeing her.
Wow, that's really amazing. So guys, please go for your mammograms, So with recent advancements in cancer care, we believe that cancer is a word, not a sentence. I'd like to ask our ladies here, what is that one tip or advice you would give with regards to breast cancer?
Regular screening, and so they can pick up early. So the earlier we pick up, the better the outcome, and the less we need to do to treat it. So cancer, like you said, is not a death sentence. It's just like a little speed bump. So we just have to slow down, get treated, and reevaluate our life. So a lot of my patients go back to live a fuller life after cancer treatment because they have decided that their priorities in life that's more important than work, and they're actually happier because they find that there's more to life than working.
Don't run away from breast cancer treatment. Breast cancer treatment is not as fearful and terrifying and does not always require chemotherapy. There are targeted treatments, immunotherapy, hormonal medicines out there that can also treat breast cancer. And chemotherapy in this day and age is no longer what it used to be. It's not terrifying where patients are vomiting all the time and are bed-bound. Nowadays, patients are managing treatment so well that they continue their work, their jobs, and continue their good quality of life.
Thank you, Dr. Jessie and Dr. Lynette, for a very fun and insightful sharing on breast cancer. We'd like to encourage all the ladies to please go for your mammograms and speak to your specialists.
Thank you.
Thank you.
That was fun.
Thanks.